Good afternoon. Thank you all for joining us for our lunchtime chats with Tlingit Haida. My name is Roald Helgeson, and I serve as our Chief Operating Officer at the tribe. And today I'm very pleased that Search's Chief Medical Officer and Senior Vice President, Dr. Elliot Bruhl, is here again for a third time to provide you with an update on the COVID pandemic and specifically the Delta variant, as well as answer any questions that you might have. His presentation will address the current status of the pandemic in Southeast Alaska across the United States, information on the Delta variant, and the importance of staying safe and getting vaccinated. Dr. Bruhl, first of all, thank you for joining us. Please introduce yourself for our guests.
Let's make sure I'm off of mute. I have a knack for doing that in Zoom meetings. Can you hear me okay?
We can hear you great.
Okay, good. Hi, I'm Dr. Bruhl. I am a family physician and have practiced in Southeast Alaska since the mid-1990s. I did take a 5-year hiatus where I was practicing at the Mayo Clinic, but I've been back in both a physician and leadership role here at Search for the last 2.5 years. I will apologize for the inadequacy of my my Tlingit introduction, but Kaidakeh yuhat duasal Yechna ayahat lukna hari hatsati shika ayahat. It's a pleasure and an honor to return, and I'll do my very best to explain things that have been developing with the Delta variant. We'll talk a little bit about the demographics of the recent surge that's been driven by the Delta variant. I'm going to speak a little bit about vaccines, and then I'll look forward to your excellent questions. My experience in these presentations in the past has been that there's been a lot of good dialogue. So thank you, Roald. Thank you for inviting me. It's an honor.
We're very pleased to have you again, Dr. Bruhl. These have been well watched and very much appreciated. So before you begin your presentation, we want to thank Search for partnering with the tribe to ensure that our citizens receive accurate information on the COVID vaccine. There are many different views and claims about COVID in the news and on our social media right now. Misinformation risks undermining public health efforts, confidence in our system, and it's important that our tribal citizens have the facts. So we want to thank Search for working with us to provide opportunities as well for our employees to get vaccinated, and we look forward to even more of these collaborations. We hope your presentation will help relieve anxiety that many of us have, and allow us to make informed decisions and also have further conversations with our health providers with this up-to-date and accurate information. So with that, Dr. Bruhl, if you're ready, let's begin your presentation.
Okay, sounds good. Let's see, we've got a presentation that my assistant should be helping us to project, and let's see here. Good. Okay, next slide. In order to talk with you today about the Delta variant, we really should review for a moment the life cycle of the coronavirus in the cells of the body, and this graphic helps us to do that. So at the top of the graphic, you'll see the coronavirus. It is a circle that's surrounded with little blue spikes, and it's got a red curlicue on the inside. It's called a coronavirus because if it is viewed under an electron microscope, it looks like a crown with all the little blue spikes on it. Those blue spikes are proteins that are on the outside of the viral capsid. They're called spike proteins. The inside of the virus contains a piece of RNA or nucleic acid that's a genetic molecule that contains the instructions to make more virus. So you can see, if you follow the arrow down, how it contacts the outside of a cell, and this large gray part of the diagram represents a cell, for example, in the respiratory tract, the respiratory epithelium of your body. And you can see how the little blue spike protein is contacting those small purple spikes. And that is really a key element in the infection of this cell. And what that is the spike protein is attaching itself to something called the ACE2 receptor. Now, the ACE2 receptor lives on the surface of our cells in many parts of the body, and is an important part of the function of the cell and its ability to communicate outside of itself with other cells. It should normally be there. There's nothing wrong with it being there. It's just that the virus uses that as sort of the front gate to come into the cell. And the spike protein fits into it, kind of like a key into a lock. And that allows the RNA, this squiggly orange, represented by this squiggly orange line here, to enter into the cell. Once it's in the cell, it hijacks the manufacturing business inside the cell in order, as you move down here through these areas, and you can see it's labeled remodeling the cell. Basically, the RNA from the virus takes over the cell and instructs the cell to start producing more virus particles. And so you can see down here in the bottom part of the diagram how there's manufacture of more of these virus particles, and then it is released out into the body, more virus. And that really is what an infection by a virus is. It's the virus particle taking over the cell. And so this is, in this diagram, it's showing that one virus is coming in and one virus is going out. But the reality is that if this was in real life an epithelial cell, what's going on here is one virus is coming in and millions are coming out. And so those millions go on to infect and take over other cells. Ultimately, this cell stops taking care of itself and it can die. And that's really where the problems are for the body in terms of trying to fight off the infection, is to stop this from happening. Next. So the genetics of this virus are very well understood. They've been mapped. And this is a schematic that shows a very small part of the overall genetics of this coronavirus genetic material. And you'll see on the bottom, there are different areas of the genetic code for the virus that have been mapped, and there's one of them that's called S. And if you expand that up, you can see there's all sorts of different parts of this genetic code that code for different areas. And this would be for that manufacturing aspect that I was showing you in the previous diagram. You can see there's the terminal domain, the receptor binding domain. All of these are different parts of the instructions that are used by the cell to manufacture more of the virus. And in specific, this is the instructions for manufacturing the spike protein. And why are we talking about that? Let's go to the next slide. we're talking about that because that has an awful lot to do with this variant that we've been all hearing about, the Delta variant. So here is a schematic picture of what that spike protein looks like. And you remember how I said it's like a lock and a key. And so this is the key that allows the virus to unlock the surface of the cells in a patient's body. And what has happened with the Delta variant is that it has changed the shape of this spike protein in such a way that it's a better key. It's able to let the virus into the cell with more efficiency. And this receptor binding domain that's labeled at the very top, that is the spot where the variation has occurred. And the variation has occurred in that genetic code. Next. It's not completely understood how that change has resulted in all of these effects, but it's become much more transmissible, 2 to 3 times more transmissible. It makes people sicker. We did not initially expect that it would make people sicker. We thought it was mostly a variant that from early reports was more communicable, more transmissible, but it turns out as our experience has grown and the data have shown that it does make people sicker. People who are infected with it do have higher amounts of the virus that they carry in their upper respiratory tract. And then the other thing that we have seen, thank goodness, is that the vaccines that we've had since back in December are effective in preventing this virus from killing people and from making them so sick that they end up in the hospital. So really good data on that, both in Alaska and nationally. So if you look in our hospitals throughout the country and in Alaska, over 97% of the people who have been hospitalized or unfortunately have succumbed to the virus have been people who were not fully vaccinated. And over 98% of the people who have passed away because of this were people who were not vaccinated. So the vaccines don't completely prevent folks from getting the infection with the Delta variant, but the vaccines are effective at helping the body fight it off so that it doesn't overwhelm their system. Next slide. So starting back last year in the fall, in the state of Alaska, the State Department of Health and Epidemiology made a decision that they would run genetic testing on all positive COVID-19 tests in the state that were not rapid tests. And the reason for that is the rapid test, when you run the rapid test, you in essence destroy the sample in running the test. So there is no residual material that you could send to the central lab. You get the answer and that's the end of it. But tests that are run that are submitted into a laboratory and use one of our laboratory testers, which are termed PCR, which stands for polymerase chain reaction. Those PCR tests, those samples there's a residual. And if the test shows positive, what they're doing is they're sending it to the State Department of Epidemiology. And then the state is testing it to see what kinds of variants there are. And that way we were able to understand what's going on in Alaska. Well, you can see going back here to the first part of the summer, the summary in early June was that about 40% of the genetic variants were the Delta, which is indicated in this rust color. And then there were some other variants that were circulating at that time. There was the B1621, which actually we talked about at the last time I spoke, I think. There was the Alpha variant. And you can see as you went through the summer that by the time we get to the end of or the middle of July, virtually all of the positives that are occurring in Alaska and here in August, really well over 90% are of the Delta variant. Now, Roald, I'm just going to digress here for a moment because there's a question when I speak publicly and when I speak to physician groups about this that always comes up. So I just want to go ahead and speak about it now. If I had a positive test, people want to know, can I know if it was the Delta variant? And can my doctor know? Can I get those results? Can I get my hands on those results? And can we know? And the answer to that is no. And this is the reason why. The tests that are done in order to determine this are of a they're not an FDA approved test. They're the kind of test that's done in a research lab or a laboratory that's associated with a university. They're highly technical determination that is not by law allowed to be reported to an individual patient. But what it does allow is it allows the State Department of Epidemiology to understand from a broad point of view around the country what's going on in the state. I think the picture is clear, and I think you can rely on the fact that if you did have a positive COVID-19 test in the last month, that it would have been caused by the Delta variant.
Dr. Bruhl?
Yes.
So as you talk about the increased transmission of the Delta variant and its ability to get us much sicker, does the treatment then change? So if I can't know as a patient what variant I have, does it really impact though the care that you're going to provide for us at Mount Edgecombe?
No, it does not. It does not. So that the treatments that we have been effective for the Delta variant as much as they have been effective for the previous Alpha. And those treatments really fall into two groups. The first is supportive care. And so that would be high flow oxygen, making sure that somebody has enough fluids in their body, and supporting any other diseases that the patient might have, that they might be in a weakened state. So if they have underlying kidney or heart disease, might need some additional support. We have some ability to directly treat this with some medications, and one of them is steroids, high dose steroids that we use for people that are very sick, that are in the hospital and have been shown to be helpful. And that's an anti-inflammatory, basically a very broad-based anti-inflammatory treatment. Not without some risk, but definitely well worth doing for people that are that sick. There's also remdesivir, which is an antiviral medication, which is not profoundly effective, but it's effective enough that it makes a difference and reduces the likelihood of death. And that's something that only is given in a hospital setting and is very, we have a fair amount of experience with it now, and it is effective. And then lastly, something called monoclonal antibody treatment. Now, what that is an infusion that's given to basically flood the body with antibodies directed towards that spike protein. And those antibodies then assist the patient's existing immune system to fight the infection. And that's something that we give to people that are in an outpatient environment. And this has been available now for about 5 or 6 months, and we've been giving an awful lot of it in the last 2 months. And we have the ability to give it in Juneau. We have the ability to give it in Sitka. We have the ability to give it in Wrangell, Haines, and Prince of Wales. It's again a fairly technical treatment, and it's taken us a little while to stand up our ability to give it in some of those smaller communities, but we're doing it. I'm really proud of the staff because it's not been an easy thing to stand up. But so yes, we do have those treatments, and they're not specific to the Delta variant, but they're effective, reasonably effective.
Thank you for that. I appreciate it.
You bet.
So the takeaway that I got from that is that while my treatment may not change, the possibility of getting sick is greatly increased with the Delta variant.
Yeah, it really has a lot of implications for public health measures that we take. It's helped us, I think, as a medical community and as a society, it's helped us to recognize the seriousness of the situation, that the virus is evolving and becoming more transmissible and more virulent. Virulent meaning more able to hurt you, and that requires really requires us to keep going forward in terms of our efforts to ensure that we increase the vaccination rate in our communities, that we take measures that we know reduce transmission and that are scientifically demonstrated to do that. And in spite of the conversations that occur in the media world, in the medical world, the data are pretty straightforward in terms of the effectiveness of masking and at reducing transmission. So I think those are important consequences of this type of information.
Thank you for taking that question.
The next slide. This is a picture of Southeast Alaskan numbers for just the last month or so, and you can see total numbers of positive cases in different communities, including Sitka in the blue and Juneau in the orange. You can see we've also been seeing some positive cases in Klawock and Haines, Skagway, and Klukwan, and which are grouped together. And also in recent days, we've had a few cases in Wrangell. So that has, it just kind of gives you a picture through time here. And you can see that the overall trend with the Sitka outbreak has generally been down, but it's continuing, and we've seen a few spikes in numbers in Juneau. I'll also say that we've seen some outbreaks in congregate settings, including bunkhouses around the region, and we've worked very diligently with the leadership of those organizations to test and isolate the folks that are positive there. And to the credit of those organizations, those fisheries organizations, they've done a fantastic job of working with us and our staff to control those outbreaks, and we've been successful in stopping things from moving forward in those environments, which which is great. Search operates 2 long-term care facilities, one in Sitka and one in Wrangell, and we've been fortunate that to date we haven't seen any outbreaks in those environments, but we've been very vigilant. Next slide. These are pictures that depict the numbers in Alaska for hospitalizations. So this is actually a pretty big deal. So the hospitalizations, hospitals are designed to run in a status of being full. I mean, that's, they're designed to carry the capacity that they have. However, what's happening is that the numbers of hospitalized patients who have COVID-19 has, pretty dramatically increased, and very dramatically increased in the Anchorage area. And those are hospital facilities that we in Southeast rely upon as a referral location when we have very sick patients. So when we need to escalate the care for somebody who's sick, not just a COVID patient, but when we have somebody who is very sick and needs a neurologist, or very sick and needs a cardiologist or a kidney doctor, we rely on those facilities for that. And COVID has made it difficult for us to be able to refer those patients out. And we've been having to sometimes send people south to Seattle. And we've also found ourselves reaching out into other areas of the state to find resources when Anchorage has not been able to meet the needs. So, and this is really all due to the COVID outbreak. Next slide. I did give a very detailed talk on vaccines last winter with this group, and just very briefly, there's a number of different kinds of vaccines that are out there. You may have heard in the news the full approval for the Pfizer vaccine. That is a messenger RNA vaccine. So you'll see here in the graphic on the left side, the messenger RNA. This is not the messenger RNA for the virus. This is the messenger RNA just for the spike protein, which is that protein we were taking a close look at the other day, and so, or earlier in this talk. And so that is really what is in the vaccine, is that messenger RNA, and they're encapsulated in little lipid spheres. It's injected into the muscle, and in the cells where it's injected, then these spike proteins are produced, which then provokes the body's immune system to produce the antibodies to the spike protein, which is the thing that makes you immune. Now, one thing that we didn't know the last time I talked to you about this, but we do know now, which is pretty interesting and pretty cool, is that we know that the amount of antibody that is produced from this vaccine vastly exceeds the amount that's produced by your body if you just had the infection. So I've received many questions, over the last half a year about, oh, well, I had COVID. Should I get vaccinated? What would be the benefit? I already had COVID and I'm immune. And it's true. If you did have COVID, your body does have some immunity as a result, naturally, but you don't have nearly the amount of immunity that you have if you got the vaccine. So you should get vaccinated, not while you're sick, but after you recover from the COVID-19 illness, then you should get vaccinated, because in effect, what you're doing and this is with the very first shot that you get from the vaccine, you will be boosting your immunity. You should get the full 2 vaccine series once you've recovered from your COVID illness. Next. This is a schematic of the Johnson & Johnson, which is another different style of vaccination that has the emergency use authorization. Has not yet been fully FDA approved. I expect it will be in a month or two. It works differently than the messenger RNA, but it ultimately ends up the same way. So in this vaccine, there's a DNA rather than RNA that comes into the cells, and ultimately, if you look in the center here, ends up provoking the cell to produce the spike protein just the same as the messenger RNA, and then that spike protein then eventually will produce antibodies. Next. The side effects of the vaccine is mostly a sore arm. Small number of people will get a headache or a fever. There's an extremely low incidence of allergic reactions or anaphylaxis to the vaccine. Experience now, with having given billions of doses of this, we know quite well how often this happens. It's about 8 times in 10 million doses. We do know how to treat that. We have the medication to treat that problem available wherever we give the vaccine. So the other question that you may hear in various settings is, is the vaccine safe? And you know, it is. It is. We have experience having given many millions of doses of it here in the U.S. And billions of doses across the globe at this point. I can tell you we have dozens and dozens of people hospitalized for coronavirus. We do not have anybody hospitalized for side effects of the vaccine that I'm aware of right now. And we haven't really seen that. Next. You may have been hearing a little bit about boosters and third doses and things like that. I wanted to touch on that briefly. The third dose of vaccine that we're giving right now is really technically not a booster. Technically, what it is a continuation of the series. So I do not have a weakened immune system. So when I got vaccinated, I only needed 2 doses. But some of our patients do have weakened immune systems and do need extra doses. And some of the kinds of problems that those people have include organ transplant patients, people who are taking chemotherapy, people who are on immunosuppressive drugs. So all of us know some people who might be in that category. So that would include a lot of people who have rheumatoid arthritis or rheumatoid arthritis-like illnesses or diseases are on immunosuppressive drugs. People who have certain kinds of diseases of the intestines, certain kinds of diseases of the skin like psoriasis, colitis. Some of those patients are also on these types of drugs. And so for those folks, the data is now in, and the data on millions of our experience with millions of these folks, and what it is that those folks should get a third shot. And that's different than the conversation about boosters. Next slide. And the conversation about boosters is that starting here in the next month, everybody who has received a previous 2 vaccine series will be recommended that they get an additional booster dose. What is still not determined is whether that third extra booster dose should be administered after 6 months or 8 months. I'm expecting that we'll know the recommendation here next week. The National Committee on Immunization Practices is meeting to review the data and make that recommendation next week. And so we'll know. I can tell you that in the meantime, we are working hard to ensure that we have all of our plans in place so that when people are ready for this, that we're ready to go. We're ready to go in all of our clinics. And it'll be premature for me today to say exactly what that process is going to be, but I'm expecting it will look a lot like our process previously, which means there'll be an interface with a QR code that you can click on either on the website or in the portal, and put in your information about your phone number and your email, and that you're and probably it will ask you when did you have your second dose of vaccine, and then you'll get signed up. So that's big picture, but the actual instructions, of course, we'll be pushing that out here in the next week or two once we see those final recommendations. Vaccines for children under 12 are probably coming. I thought they were going to be coming in the fall, but it might actually be closer to New Year's. So that's being worked on. Right now, the messenger RNA viruses are approved for teenagers down to the age of 12. So go ahead and we can end the presentation here.
Dr. Bruhl, thank you for that presentation. I have some questions, but I'll have to say that all of our wonderful viewers out there also have many questions. So I'm going to hold my questions and see if there's still time at the end. Instead,
Okay.
I go to the public. And if you have not had a chance yet to put your questions in, please type them into the comment section, into that chat box, and we'll be happy to try to get through as many of them as we can with Dr. Bruhl. A lot of positive comments out there, Dr. Bruhl, about Search, thanking them for being so informative and for the hard work that's been done around vaccination. So I'll get to the questions. I think that's really what you're ready for.
Yes,
and Rob's asking, how long does the Moderna vaccine last? Do you have information on that?
The Moderna vaccine really lasts the same amount as the Pfizer. The two are interchangeable. They really are, in terms of our understanding of their effectiveness and their side effects, their method of action. They really are designed around the same principle and have many of the components are identical. We saw in the pre-use there were some slight variations in effectiveness, and those, as they've been given out to millions and millions of folks, they really are. The only difference is the manufacturer of them and some of the research that was done early. So if it's 6 months or 8 months, it's going to apply to both. And just to tell you also, I'm expecting that we will use them interchangeably. In other words, if what we have, if you had the 2-shot series with Pfizer and what we have available is Moderna, we'll give you Moderna, or vice versa, because we understand that they are interchangeable in that regard.
Oh, for that, I had not heard that before, and so I think that's important. Ruth is asking a question, and her question is, are we needing this 3rd shot because of the Delta strain?
Oh, great question. Yes, I think so. I think before the Delta strain, we were not seeing we weren't seeing the spike, the second wave that we've been seeing in the United States and in some of the other countries. I'll also say we're needing to do it also because of the fact that we have areas within our country where vaccination rates are low, which is really something that has contributed greatly to the resurgence. So, I mean, there are certain areas where the vaccination rates are less than 30% in the general population, and those have become areas where the virus has just become much more widely circulated, which has necessitated an additional response. So I think it's a combination of things.
Thank you for that response. And you may have answered this one in your presentation, but Francis asks, will there be a booster for the J&J or a second shot for the J&J?
I didn't answer that, and I do not know the answer to that.
Okay.
I suspect yes, but currently there is no recommendation on a booster for that, and there is no formal recommendation around whether people who have had J&J should get any boosters with anything.
Okay.
I think if a person has a question about that, I think they should feel free to talk about it with their physician, and they can consider those possibilities on an individual basis. But there's currently no plan or recommendation for that.
So I think you mentioned dates are coming for the end of September. Bev is asking when would we see the booster shots available at Surge?
We hope to start on the date that they're. I mean, we see this coming. It's just over the horizon, and we are working on the logistical processes. And our goal is to be able to offer it when it's recommended by the health agency's leadership that we do so. And the date that I've heard, although this I'm sure will change a little bit, but the date that I've heard was September 20th. But I mean, it's coming, 3 to 4 weeks from now.
So Harry's asked a question, which is kind of a variant on the earlier question, but is it safe to say that if more people got the vaccine, there would not have been a Delta variant?
Oh, what a great question. I mean, in the sort of the big sort of theoretical sense, yes. I mean, if we were able to vaccinate a substantial portion of the global population, the unfortunate thing here is that the Delta variant emerged in India, where there was extremely low vaccination rates and extremely high numbers of people that were infected. So I'll just say a little bit more. Viruses evolve always. There's always possible with any virus, and we're familiar with that phenomenon. It's not anything unique to coronavirus, but so like every year, we give a different flu shot. Why is that? That's because the influenza virus has the ability to change and evolve every year. And what happens is that the doctors who specialize in this kind of area of medicine have learned that what they do is every year they go to southern China and they look at the strains of influenza that are happening in the swine industry in southern China, and those variants that are there, they know will show up the next year as the epidemic flu that we experience in the winter. And they've just learned that through long experience. So they go there and they build the vaccine based on what they find genetically in those swine. So because pigs and humans actually we share the influenza virus with each other. So, which is unusual. With regards to this, when you have every time a single individual is infected with coronavirus, there are millions and millions, if not billions, of replications of the virus in that person's body. And if you consider millions and millions of people being sick, and then the billions and billions of replications, there's always a chance that one of those replications will produce a variant, and that variant will in some way be more infectious. And so ultimately, the best way for us to end the pandemic is to get everybody vaccinated, as many as we can, and stop it from circling around. So I hope that answers that question.
I think it does. There's a couple different questions along these lines. And so I'm going to merge a couple different questions, and please, I hope our public will forgive me for it. But some people have been vaccinated, they've contracted COVID, and some people unfortunately have passed away from that. And that causes some fear for people in vaccination. Do you have anything that you would share with our public and our citizens about that?
Yes. I guess the first thing is to acknowledge the fact that that's true, and it is frightening, and it's frightening for us and for you. I mean, this is a bad situation. I mean, it's undermining our health system by filling up beds and by creating a situation where staff are just overworked and mentally exhausted. And there's many different ways that this is making it hard for us to take care of ourselves and our communities. So I don't think that there's reason to lose hope. I don't think there's reason to be overly fearful, but I mean, it's like there are threats, and this is a real one. Some people who are vaccinated do get a quote unquote breakthrough infection with COVID-19. What we know, the science shows that they have much lower levels of the virus in their body and their system, and that overall that they have a much higher rate of survival, and that they tend not to land in the hospital. Unfortunately, that's not a guarantee. It's not like a light switch. So there's some individuals very tragically who have been vaccinated and have ended up in the hospital and have died. I mean everywhere. So there's no guarantee. But it's really an amazingly effective vaccine, much more than most. So 97 to 98% effective in preventing those outcomes, which we don't want. So there's good reason for hope. And and the other thing is that we've got really wonderful scientists, great minds that are working on this, and I I believe strongly in the ability of the medical and scientific community to continue to face up to the challenges that we have here.
Thank you for that. And I know that combines several questions into one, and I hope I kept the flavor of what people really wanted to know. You mentioned influenza, and one of our citizens, Penny's asked, any problems getting a flu shot at the same time as getting the third vaccine?
Great question. I don't believe so. I think that we can give people both at the same time. I have not seen when the ACIP, the Committee on Immunization Practices will give us a formal rec on that next week. But we're hoping that people could do both at the same time, and we're plotting to be able to hopefully do that and make it a little more convenient.
So I'd just like to correct myself for our health providers out there who will remind me this is a influenza vaccination and not a shot. So,
yes.
so people could not Facebook me that later.
Yeah.
So Jenny asked a really good question. And how do you know that people isolate when they are positive or exposed and recommended to isolate? Do you at Search track them and check in with them?
No, that is a function and process of the State Department of Health. So there's laws about that, really, that designate that in an epidemic that is the role of public health in our country, and that is the role that they perform in our state. And honestly, just recently with the outbreak with Delta, they've been doing a pretty good job of doing not just notifying people that they have it, but checking in with them. But they have gotten at times overwhelmed, and they've lagged in that. And we have in certain places and at certain times we've stepped in to support them with that and to make some additional calls and so on. But that is not our primary function. We're not staffed to do that. That's really their job, and we have seen that for the most part they've done it. They've had some variation in their staffing, but most recently they've got several hundred people, I think, that are doing that full time.
Rhonda's asked, the City and Borough of Juneau and DHS has recently stopped providing active cases to the public. Not just, we know that new cases are being provided, but active cases aren't being provided. And Rhonda believes that these numbers are really helpful in identifying communities engaging day-to-day practices. Is Search able to provide those numbers to the public? Do you get those numbers?
We don't. I mean, we receive them from the state the same way you do, I guess is what I would say. And we're not the sole tester or, the center point of those data. The State Department of Epidemiology is. Now, I know recently there's been a transition going on in reporting where the state has been in essence, sort of taking over the dashboard function for a lot of the communities that previously were providing those data through their emergency operations center. So, and I know I was not aware of the fact, though, that the state was not providing the total number of active cases. So I can't speak more specifically to that.
Well, thank you for that. I know I'm watching the clock out of one corner of my eye as we're getting close to 1 o'clock. So I'll try to keep moving through the questions for
Yes.
you. Rob's asking, what are your thoughts on the start of the school year? And I assume that's with COVID and masking. What are your thoughts on this?
Well, I'll tell you, I've worked with a number of the school districts around the region to help them with their mitigation plans. And my message to the districts has been consistent, and that is that cohorting is very, very important. And by that I mean to as great a degree as possible, while supporting the education of the children, to not have all the kids mixing with all the kids all the time. So that becomes a little more of a challenge in the higher grades. But the problem is that if we do have people that are contracting COVID, and we will, I mean, you can count on the fact that that will happen. If you don't have the kids just educating in one classroom or with one group of kids, then you end up having to shut down the whole school. On the other hand, if they're cohorted, you can say, okay, this group of teachers and this group of kids need to step aside, do homeschool for a week or 10 days or 14 days, whatever it might be, in order to ensure that we don't have a continued outbreak in that group. But the rest of the population of that school can continue onward. Masks are very important and critically important in a community where there's community spread. The kids need to be wearing masks, and in a community where there's not identified active cases and community spread, they can back away from it if they'd like. I don't think that's unreasonable, but when there's active cases that are spreading through the community, the kids should be wearing masks. I think one of the things that we were all impressed by last year is kids do fine with masks. It's like putting a scarf on a kid, you put it on and they go. And they're like, oh, okay, mask. Now, some of them take it off, of course, and they have to be reminded. And we know we can probably anticipate which individuals those will be. But masks, we haven't really talked a lot about masks, but I'll say, the data on masking that's in the medical journals is very clear. Masks are effective. They're effective at reducing the amount of particulates that we expel into the environment around us. That's been proven. And that they reduce the transmission of coronavirus. That's also been proven. And you can go on to the New England Journal of Medicine website, and you can see the articles that have been published about that. So,
you have time for just one more?
You bet.
Okay, and this is a little bit of a longer one, so I'm sorry for that, but recognizing we have long haulers out there, and when it comes to COVID, Jerry's asking, realize that there's been limited time to do detailed research, but wonder if science has identified any lingering residuals such as organ damage or potential for something such as shingles waiting in the system. They're concerned specifically about our children who are unable to receive a vaccine protection yet. And they thank you in advance for the information.
Wow, what another great question. Well, let me just speak a little bit about shingles, since that is a distressing condition that, is a reactivation of an old virus in the chicken pox. So there is absolutely nothing that we are aware of in terms of the biology of this virus, that the virus itself becomes dormant and resides in a part of the body after the infection is defeated by the immune system. That's not been identified in any studies or reviews that I'm aware of. Just to recap, what's going on with shingles is that when we were kids and we had chickenpox, our immune system defeated it, but the virus itself retreated into the dorsal root ganglia of our spinal cord and lived there for the rest of our life. And in most of us, that's a non-issue. And for people with shingles, they reactivate and they get and the virus reactivates, and they get it in a specific spot on their body through the nervous system. That is not been identified in this situation. The lingering effects of the coronavirus illness on organ systems, for example, people not being able to smell. They have been searching to see, is there a residual infection in the nervous system or whatever, and it's not been identified. And it's not understood. So that's there's there's many things that are not understood about those.
Well, thank you for that question. There are so many more questions that the public has out there. Is it possible for us to send those over to your office, and maybe some of your staff could look at them, and if there's some answers that really are pressing, that we could in turn share on our social media page?
Sure.
Okay.
No problem.
I respect that there's just not enough time in the day, and obviously this is the issue of our last 18 months.
Yep.
We just want to express our great appreciation to you, Dr. Bruhl. Thank you for joining us. We appreciate you.
I'm honored, and our staff really deserve all the credit for the work that they're doing. So I will pass that forward to them. Thank you.
Well, we're all behind them, and we lift you all up as you're taking care of our family and our friends. So thank you to all the public. This wouldn't be a lunchtime chat unless you were out there participating with the wonderful questions that were out there today. And to close out our chat, thank you for tuning in. We've randomly selected some winners for this afternoon for those who have joined us on the Facebook Live event. And for the first drawing of the for door prize winner, Hydro Flask is Daniel Goheen Sr. And then for the David Boxley Formline t-shirt is Angela Porter. So to everybody, Hawa, thank you for joining us today. We hope you enjoyed this very important lunchtime chat. We want to thank our sponsors, Sacred Ground, Smokehouse Catering, Sacred Shine, and the Elizabeth Paradovich Hall. So these programs are up and running and doing things in a very safe way. So we look forward to talking about the upcoming lunchtime chat soon. The topic will be determined, and we will be sharing that out as quickly as we can. Again, from our studios here at Tlingit Haida, and with our partnership at Surge, we want to thank you for joining us, and we wish you a great rest of your Thursday.
Yep.
We'll see you all again. Thank you, Dr. Bruhl.